So the essence of what you'll see there is from the Innovation Center. Obviously, I'm representing both the Innovation Center and Tribe and all of the partners that we work with. We have a bit of a doubling down, if you will, on connected health, telehealth, and population management, which is what we are mostly going to talk about here. We're doing currently 42 concurrent projects. Probably that means we're doing most of them not very well, but we are trying to do at least some of them with impact. I'll start off actually giving some quick attention. Let's see if we can do this. So the centerpiece in some ways is David and Kevin's, this is not working. Oh, there we go. CMMI grant project around medication adherence post-heart attack. And it's just, I think, a great story about why we're starting to believe in connected health and the impact that the combination of behavioral economics and these technology platforms, we have streaming data that allow for early detection, early diagnosis, and different kinds of interventions can work. The baseline, which is one of the data points I was getting about, this slide is 20 minutes old. So you have that line sloping down on the baseline. That's from the PI of the MI Free study that Kevin was emailing with about 10 minutes ago. And you see that it's about average about 45% over the course of the first year. This stops at 25 weeks, but it actually represents the first year. You can see that it's dated 10/31, so I should have updated my slide there. And we're up at 90% versus a baseline of 45%. So a dramatic difference. And this is post-heart attack when you're talking about medications that aren't that expensive, aren't that hard to take, not a lot of side effects. And as you're talking to the people who are exhibiting these different behaviors and some sustained behavior change, a lot of it isn't actually the incentives per se, not the money part of the incentives, but the fun part of the incentive, that someone's watching, paying attention, looking at it. So this is, of course, where the pill bottle, for those of you who don't know, is broadcasting whether the person took their medications or at least opened that pill bottle on a given day. We can use that data to then say, okay, is this person in the lottery? Do they miss the opportunity to win money in that lottery? And extending this idea of streaming data that allows us to do fun things. So some of you know this competition we did last year. Many of you I see out in the audience participated in it. It was a fun little hack in some ways. It was about a 2-week-long study, taking the free Moves app, a pedometer on your phone, putting it on 96 phones across the health system, and that was team-based. So it was 24 teams of 4, and it was really an interesting thing to watch. Where it was pretty much all anyone talked about that week over in Promen. It really was quite the buzz, and you start to see these sort of social interactions of people saying, hey, get up off your butt and walk. If I was on your team, I'd be texting you 3 times a day. The winning team texted each other sort of constantly, so there's really interesting social dynamics. And what we found by doing this, not only did we sort of triple the baseline of people's activity, but we learned a lot that we got wrong. Which is the goal wasn't really to take active people and make them hyperactive, which is kind of what we did. Take these crazy competitive physicians, and take them from 10,000 steps a day to 40,000 steps, which I think was Gary Scheib, the COO, who peaked out. But the incentive structure we used is wrong. A lot of things we did were not right, but it was this fascinating learning to do it within a week. And so Kevin and David adopted this, being led by Mitesh, David and Nancy, so a great team who's now moved this over to the Way to Health platform, and where we can turn it into a real automated hovering study, where we're going to start to try to get some of those incentives right. So again, it's going to be team-based because the team dynamics were really overwhelmingly interesting and positive, where you just take this app, you put it in your pocket, and you forget about it, and you just spend your day doing whatever you're going to do. We're capturing your steps. We're starting to organize and say, well, how did this person do? How did this team do? Most of them are team-based with some individual-based competitions, and then communicating back to the folks the way that Way to Health allows for that intervention. And so it allows us to test some really interesting things. It is fairly broad-based across UPHS, Penn, IBC. The 7,000 steps a day, there's some evidence, I'm not going to go into it here, about why that's a reasonable number to pick. But again, we're going after sedentary populations now. And so in terms of some of the things that we got wrong that we're trying to study, when you're doing a most steps wins competition and you're a less active person, you're looking up at the top of that chart going, forget it, I'm 100,000 steps behind, and it's not very exciting. And so sort of relative leaderboards versus absolute leaderboards, comparing to the sort of the 50th percentile, how you're doing relative to comparing to the 75th. Forgiveness, people fall off the wagon. So being able to say, do you get your incentives if you're perfect, or you get your incentives if you mess up a few times? and see what does that do to activity levels, and what does that do to sustained behavior around activity, and changing some of the lottery and financial designs as well. Play with some of the elements around anticipated regret versus people who do tend to overweight low probability. So you have lotteries that go from 1 in 4 chance of a few dollars to 1 in 400 chance of $500. We're also taking it on other platforms and experimenting here. So AirCare is one of the companies that came out of Dream It Health, which was our incubator. We started 10 companies. It was a platform that was based on a bunch of the insights we had in working with CHF patients and some other populations as well, where people, even in a perfect discharge, it was imperfect. I mean, people weren't there at a point where they were ready to absorb information, could understand information. They just wanted to get the heck out of the hospital. So really, working on better discharges didn't seem very useful, actually. And so this is sending people home with a tablet or connecting with phone calls after they're already at home. So eyes and ears beyond the hospital, we're still in touch with people when they're in their homes. And there's an example of one of the questions that got created with the care teams and the clinicians, because a lot of the things we saw were people were taught about watching out for developing a cough. They get home, they develop a cough, they'd forget, they wouldn't think of it as a symptom, and they'd be back in the hospital. So we're getting, again, this daily streaming data, and it turns into a dashboard for the care teams where each patient, basically each row is a criteria or a question that the care team defines. Each column is a day. And you can see on Margaret Hart on the bottom there, there's 2 red dots, meaning there's something going on you need to pay attention to. So this is exception handling in a population. If you're handling 1,000 people, here are the 17 you have to intervene and do something with in this particular day. The physicians are loving it, and they're finding lots of catches I'll talk about more in a minute. Joe Frieder just wrote up in Health Affairs this month a 6-year study in a very similar way with 3,000 CHF patients, where he's talking about 44% fewer readmits and $10 million saved. Part of that is just sort of the employee staffing ratio, where you normally would have, this is 3 to 4 nurses that they were using, and you'd have those 3 to 4 nurses, each covering a few patients as opposed to a population of this magnitude. So we're starting to believe that there's really some interesting things we can do here. The commentary beyond the physician from the nurses and the patients was equally strong, that it's sort of addictive, and they have these different feelings of confidence and comfort and connectedness and engagement because of the way we are staying with them once they leave the hospital. So it is a little bit more accountable. We're not an ACO, but we obviously have risk-bearing contracts, and everybody is moving in that direction. So, way too early to claim victory on this approach, but some interesting data on the HUP pilot was no preventable readmissions. This is after 2.5 months. The care team, this is qualitative, felt that there were 24 incidents they caught by seeing things streaming in off these tablets that would have been readmissions. So again, judgment applies here. They're not yet saving the care team time, which is one of the things we had hoped to see, and we didn't. It's not actually reducing the time of but this was actually an inpatient staff trying to do it. This one was led by Joyce Wald. And again, there's some really interesting models out in the world that are promising. In that same Health Affairs article in the VA, you see some of these long-term studies that are really kind of remarkable. I need to dive into the numbers a little bit more to understand exactly the dynamic of what's going on. But you have large-scale studies, people with 1 to actually it should be 6 or more chronic illnesses, big reductions in length of stay, big reductions in readmission, and this is from their telehealth, telemonitoring, and coaching programs. So the next thing I wanted to hit really briefly was our innovation grant program. So David and I are actually rolling out another round of the innovation grants. We did 5 in this past round, and that was probably a few too many, but it was actually a lot of fun and really interesting projects. I just wanted to feature 2 of them, the point of this section being we would love everyone to apply for this next round that's coming up very, very soon. You should be getting notifications in email. But a lot of fun for us to actually work with Shreya, who's in the audience over here, and for those of you who don't know Shreya and her impact program, community health work is a new model. I know she's going to talk about the specifics of this, but the reality is that most of the things you find out there are not evidence-based, they're not really effective, and this is just a critical time, not only because of accountability, but because of these high-risk, more vulnerable populations that we want to help and help to have better health outcomes. And so it's something that's Shreya's passion to make sure that we're disseminating models that work, that are effective. And so it was fun for us to work with her. The grant went towards creating a website, creating a program, helping kind of walk this line between academic dissemination and actually program dissemination. It's really funny when we put up the website, and Shreya was published in JAMA very recently. We had 20 health systems coming in saying, this is important to us. and we actually want to talk to you about rolling out your programs at our location. So this ranged from, you can see some up here, New York State Department of Health, Lancaster General, Brigham and Women's, Columbia, Keystone Mercy, Intermountain Health, and AmeriHealth. There are quite a few others, but 20 organizations who came in and said, we want to know more about your program. That program is a 3-tiered program, this is the part about, the first line there, dissemination, balancing a business model and academic integrity. There are some new paths being worn here. When you're putting things out there and wanting to be paid for them, but you also have this culture, and very appropriately so, of putting information out for free that other people can leverage. I'm out of time. There's some new things we had to figure out. So this is, on the left, the toolkit. This is, when Shreya looked at an intervention that worked, this is actually captured in manuals that are free to the world. There are technology platforms that are not free that we can actually use to support other people's programs, and then consultation of customizing and implementing this program elsewhere so it's effective. But I love Shreya's quote, if you discover a molecule, there's a path. In other words, there's certain things the university knows how to do and go from discovery all the way to implementation. In healthcare delivery, that's not the case, so we're figuring it out as we go. And the one I'll end with is Telederm. Telederm is another one of fun telehealth and connected health project. Carrie and Jules, dermatologists here, really great evidence again out there that obviously you all know that there's too few specialists in general, not just dermatologists. So you have poor access, not very good coverage. Huge incidence of missed diagnoses and misdiagnoses both. So when there's some great studies that are in the footnotes I can give you around when you have dermatologists involved. They're actually not only catching things and catching them earlier and better, the way we're taking care of patients is much lower cost, often outpatient, and very much avoiding admissions. So similar to what we talked about with Way to Health, they have an app, which is a connected app. You can get images. It's a store and forward model. It has been shown to be acceptably equivalent. And Kaiser actually just was started to talk about some results they've had, which talks about access and bandwidth of the dermatologists, a lot of which has to do with not having to travel to go see patients in many cases, freeing up enough time to actually see a lot more people. The 50% was a surprise to pretty much everyone, that they actually could free up that much capacity. So we're trying to understand exactly how they're measuring it and what it is that they're measuring. And the final slide is we are trying to refocus again on employee health as a gateway to population health, where if you look at the double diamond model that we use for innovation, from contextual inquiry and cultural anthropology on the left, all the way over to these rapid cycle validation on the right, various projects are in various states. David has a dream of making Penn Medicine no more intensive, so we'll see if we can get blood pressure down across the board. There have been some really neat connected health models for that. One rolling out at MIT actually showed ability to get, in a connected health way, blood pressure down about 26% in 3 to 6 months for $50. So a much lower and more effective approach to some really intractable problems, and ones that are less visible than problems like obesity, so they sometimes don't get as much attention. Back health, some of you heard, is our number one issue here in terms of a cost driver. Our $100 million that we spend on our own population, about $20 million that we spend between back problems and other musculoskeletal. Access urgent care, we're trying some clinics over in Penn Tower and Ahmed that we're going to see what goes on there, and moving forward with what we've already done around the policies around smoking, obesity, and fitness. So that's just some of the things we're starting to work on. We'd love to hear from anyone who wants to engage with us, who has ideas, and please apply to the next round of innovation grants. Thanks.